Right now, in terms of standard of care, chemotherapy really is the standard of care for frontline, except for patients who are untreated and have a 17p deletion. It's those patients in whom ibrutinib is the first-line choice of treatment. And that's the only group where the small molecule inhibitors are indicated frontline for treatment. For younger fit patients who can tolerate chemoimmunotherapy, FCR is favored over BR, although there is some data that the FCR regimen has a higher cost of myelosuppression and perhaps infection. The progression-free survival is improved for FCR over BR, and for the young, fit, chemoimmunotherapy eligible patients, that's the standard of care. For the older patients, patients over 65 or frail patients who have comorbidities, chlorambucil obinutuzumab is the standard frontline therapy, and that's based on a large randomized trial. And that trial showed that obinutuzumab was superior over rituximab in terms of efficacy. And that chlorambucil obinutuzumab combination is preferred over chlorambucil rituximab or chlorambucil monotherapy. There is some data also with chlorambucil plus ofatumumab, which shows improvement in outcomes for that combination over chlorambucil monotherapy. But whereas the chlorambucil obinutuzumab trial showed overall survival compared to chlorambucil, the ofatumumab study did not. So the ofatumumab chlorambucil was superior in terms of progression-free survival over chlorambucil, but not in terms of overall survival. So that survival advantage with obinutuzumab directs me to recommend that as the standard first-line therapy for the elderly population.